Well, I would like to officially welcome everyone to this 14th live session in the COVID Advocacy Exchange. We are deeply, deeply honored to be back together and to see how far we've come just since starting this program earlier this year. I will be honest, preparing for today's session has really affected me. It's given me a deeper understanding of the ways that the issues we're going to talk about affect people, and it has certainly helped me gain more empathy to the ways we are affected in these different areas. And so before I turn it over to a man that I respect tremendously for his character and his work, I would like to start by asking everyone a question, if I may. The question for you is, how would you like things to be different after today? And how would you like to be different? As we go through these conversations, I encourage you to please keep that idea in your mind, because these will be some powerful and really authentic conversations. And at the end, before we wrap, we're going to have a specific call to action for the change that we want to see and we want to create together going forward. So without any further ado, I am deeply honored to introduce John Diamante, who is the president of the BMS Foundation. Hello, John.
Hello, Dave, and thank you, and good morning, and good afternoon, and good evening, everyone. It's a real pleasure and honor to be able to take a few minutes to make some opening comments on this very important topic. And, you know, I had a conversation. I have twin 16-year-old girls. And so I told them what I was doing today. And they say, well, that's interesting. What are you going to talk about? And I said, well, I'm actually going to talk about the lessons that we learned working on health equity over the past 20 years. And they said, you know, that sounds like something old people would do. And I said, well, you know, I think you're right. And actually, you know, I think I'm too old to have 16-year-old daughters. That's the problem. So anyway, what I'm actually going to do is exactly that. I'd like to kind of go back and talk about some of the early lessons we learned working on health equity and health disparities in sub-Saharan Africa in 1999. And the reason I feel comfortable going back to a time that fortunately isn't a time that we experience now, dealing with HIV on the continent, is that, you know, we learned so many lessons early on that actually have fundamentally become kind of like the foundation of what the Bristol Myers Squibb Foundation does in all of our programming globally. We never tend to veer from the concepts that we learned back then. And if you just bear with me for 5 to 10 minutes, I just want to take you through some of those lessons. You know, actually, as I had mentioned, we started in sub-Saharan Africa in 1999, right? So let's think back to what HIV on the continent was like. 90% of all of the HIV cases were in sub-Saharan Africa. And unlike the developed world, where we had multiple combinations of drugs and we actually were able to turn it into a chronic condition, drug was just not available in sub-Saharan Africa. So here comes the Bristol Myers Squibb Foundation, our company who was a global leader in HIV, decides that we are going to make a landmark commitment to really help support sub-Saharan African countries in the development of infrastructure and capacity to address HIV. So interestingly enough, here comes the Bristol Myers Squibb Foundation. We have a commitment of $100 million over 5 years. Now, doesn't sound like a lot of money in the face of an epidemic, but if you think back to 1999, it was before the Gates Foundation was involved in global health. It was before PEPFAR, it was before the Global Fund, and that $100 million was actually the largest private commitment of its kind. So we went to a part of the world that we actually did not have much experience in terms of the work the foundation was doing. And unfortunately, the way many of those countries, and initially the 5 southernmost African countries of South Africa, Lesotho, Namibia, Botswana, and Swaziland, now Eswatini, were also not only the countries that had the highest HIV infection rates, but also probably the most politicized. So here we come, $100 million from the Bristol Myers Squibb Foundation, and most of those countries would look at us and say, you know what? Bristol Myers Squibb is not a philanthropy company, it's a pharmaceutical company. And what we really need is drug at affordable pricing, not your philanthropy. And it was a difficult discussion because they were absolutely right. And while the company was working on the actual pricing of pharmaceuticals and HIV compounds so they could be more readily available in this part of the world, and prior to then, all the multilateral, bilateral, and national governments to be able to support it, we were there to help build the capacity and to help really build infrastructure. So when that drug was available, it could be effectively delivered. So what they were basically saying to us, in a sense, was, do we really trust you? Or are you actually looking to create a market to sell expensive HIV products into? So the first thing we started to do was, at the end of the day, the most important thing was to build trust with our constituents. Those were patients, those were treating organizations, community-based organizations. Those were especially the ministries of health of the 5 countries. And what did we do to actually help move that along? The first thing we did is that we hired completely colored and Black African staffs to run the program. This program, we had decided, was not going to be run from 345 Park Avenue in New York or Princeton, New Jersey. It was going to be run in sub-Saharan Africa. It was going to be run by Africans for African solutions. And that whole forward-facing approach to having individuals from the local markets and the local organizations and the local countries being our lead and being the conveners and being the implementers went a very, very long way to building that trust. Okay, so I just take a look now, if we fast forward, where, let's say, Bristol Myers Squibb Foundation is with one of our new commitments. The whole issue of trying to recruit diverse populations and minority populations into clinical trials in the US is quite a challenge. And a lot of people are working at the community-based level to really try to do that, to make sure we have the right representation in trials. The foundation said, let's take a long-term approach, because this whole concept of building trust with the individuals you have to interact with is critical. So we have just recently made a $100 million commitment to train 250 diverse clinical investigators in the United States over a 5-year period, and to also provide 250 underrepresented minority medical students the opportunity to be mentored by these young investigators. The concept is, we want individuals to build a trust and recruit patients who actually look like them. It's a fundamental understanding of how we think about our programs, whether it's in clinical diversity, whether it's in our programs around the world, is to really build that representation. So first lesson, make sure your organization looks like the populations you're looking to serve. You know, not exclusively, but make sure you have that representation to build that trust. Part 2 of the whole African experience was the ability for us to try to really look at building a transparent program. Again, a lot of suspicion, a lot of mistrust. So we created, like many of you do, advisory boards. And we went out and actually developed advisory boards on the community side, on the treating side, and especially on the governmental side. Those were some of the most difficult discussions we've ever had. I mean, they were very hostile at times. It's nothing, you know, presenting on panels or anything, nothing like being shouted down in terms of your intentions. And there was a lot of discussion at Bristol Myers Squibb at the time to say, you know what, this is very difficult. You know, perhaps we should pack up the tents and maybe we should move to West Africa where it won't be so politicized. But the ability for us to stay there with local staffs and to start to build that trust went a very, very, very long way. So I guess one of the things that's really interesting is, you know, where we were in 1999 and 2000, where the ministries were very suspect of who we are. 2 years after that, at a World AIDS conference, being on a panel with Bristol Myers Squibb and our partners about how to build effective public-private partnerships. So end of the day, you know what, lean into discomfort, because when you want to move the needle, you have to hear all the voices and be transparent. One of the more important things that we learned early on, back in the early days of Secure the Future, as the program was called back then, was the role that communities play in effectively delivering medical innovation and care, right? So it's interesting. We had, back in the day, two distinct advisory groups. One worked specifically on looking at the operational research and care for treatment, and the other program on the other side of the room actually focused on community outreach and education. We learned rather quickly that whatever those physicians and researchers came up with in terms of how do you effectively treat in resource-limited settings never had any sort of traction unless the community was fully engaged in bringing that to their constituents. You know, we always kind of think about that whole concept. We used to call it at the time, you know, the half hour in the clinic versus the 23.5 hour of the person's day when they step foot out of the clinic, and where the challenge begins. And we all know that back in the day in the HIV side, it wasn't the half hour in the clinic and the 23.5 hours in the day. It was the half hour in the clinic and the 6 months when they're in the community. It was critical to actually develop community support structures that could actively and effectively work with the healthcare system so that individuals can really benefit. I mean, many times in sub-Saharan Africa, it wasn't the fact that they wanted drug. They'd rather be able to eat than actually take medication. And we all knew that on those medications, you actually have to be able to eat. So how do you really start to think about community-based gardens and mobilization and bringing those non-traditional players to the table? Fundamentally, if you take a look at the Bristol Myers Squibb Foundation work over the years, it all comes down to the same thing. How do you think about bringing down the barriers that exist within a health system, right? So health system strengthening, and how do you effectively tie that to community mobilization and support? And understanding at times that, you know what, the medical community doesn't always effectively understand how to speak and work with community health. They know how to treat individual patients, but how do they treat communities? And that's a lot of investment that we have to put in, but it's really essential when we think about health disparities and health equity, how we bring those two together. And in many cases, having to invest in the development of human resource capacity to make that all work. Early on, many of the organizations we were working with on the ground were nascent organizations. Many had kind of evolved from the apartheid side, and they weren't very strong organizations institutionally, but they were passionate, they were smart, and they were integrated. And for us, in many cases, you could have easily walked away from those organizations and said, you know what, I don't think I can fund this organization. Internal audit's going to be going off the wall. But the thing is, we actually put the resourcing into those organizations, those non-sort of traditional organizations to do it. And I think one really needs to think about where we are on COVID vaccination. And we think about COVID acceptance. We've gotten good news about that happening. But there's also a lot of resistance about vaccination. And I think it's the whole concept that we need to think about now with all our partners, regardless of the therapeutic areas you work in, that you really need to think about vaccination acceptance and how we could bring those non-traditional players to the table. It'll be the pharmaceutical industries and the research centers that'll discover the drug or the vaccine. It'll be healthcare practitioners developing the vaccination. It has to be the community that's going to open the door so those individual patients can walk through it. And that needs to start now, not when it's ready to be delivered in 6 to 8 months. So again, communities are essential to everything. The other thing is be realistic in goal setting. You know, when we started off early, I think we tried to do a bit too much, and I think we sort of disenfranchised a number of partners that we were bringing along. So the thing is, you know, basically be focused, be focused around what's realistic in your strategy. And you know what, if you're going to fail early, fail quick, change course, and get on with it. I mean, all too long, people want to drag things out because they made public commitments hoping they can correct things. If you can't correct it, cut your losses, realign, and get going again. And then finally, one of the things that we always continue to understand is we continue to learn as we go forward. So, always seek to understand and engage on the structural barriers that really stand in the way of health equity. I think 2020 brought to light more around what structural issues around institutional racism can actually have on the how should I say it, on the sustainability of what we do. We can run, multi-year sort of demonstration programs with the intent that we're actually going to be able to demonstrate that these could be effectively picked up by government, by hospital systems. But if we're working in a system where we see inherent racism, how far do these programs go? I mean, is it just that we invested all this money and all this M&E and all this advocacy to help 250 people in a study? Or are we really going to take a look at what stands in the way of making that successful? I'm going to just finish up by saying that, I also have responsibility at the Bristol Myers Squibb company for patient assistance. And one of the things we have is a patient assistance foundation. And if you come to the patient assistance foundation and you cannot afford your drug, you will get that drug free of charge for as long as you need that product. And that's pretty much consistent among most pharmaceutical companies in the US. We had a patient at an advisory board meeting talk about his sort of journey to get to a patient assistance foundation. I mean, the bottom line is just having a mechanism like a patient assistance foundation does not actually guarantee access. You have to think about all those structural barriers that stand in a patient's way to actually even get to the front door of that foundation to make a request for drug or that individual's doctor. Think about those structural barriers. Make sure you challenge your partners on those structural barriers. Who are the partners that are saying they can actually help you do that? What do they look like internally? You kind of go back to the second point about leaning into discomfort and some of these difficult discussions. Have them. It's going to make a huge difference. And I just want to say in closing that, like many of you, we spent much of our time over the past 20 years working on supporting community health workers and frontline workers on all of these issues. And I just want to kind of point out that it's sort of heartwarming living in New York City that during the COVID peak here in Manhattan to actually hear people cheering on frontline healthcare workers. So they're the best. Invest in them, pray for them, and let's do our work. So I thank you for listening to my rants for a while, and let me turn it back to Dave.
Thank you, John, very much. What you said that really touched me is the leaning into discomfort. That's the heart of authenticity. And I know that I was raised to be, polite and not rock the boat too much. And with these issues, we have to be open to those conversations and leaning into discomfort. And I just love how well you said that. Thank you. So I'm going to turn it. Yeah, of course. Thank you, John. I'm going to turn it quickly to our next speaker, Perry Halkitis, who is the director of Rutgers Center for Health, Identity, Behavior, and Prevention Studies. Perry, I will let you go right into the important stuff you're going to share. Thank you.
Let me unmute myself. Kristen, let's not start the slides quite yet. I actually just wanted to reflect on a couple of things that John said, because unlike Dave, I was raised to be polite too, but as a child of immigrants, I was learned to also to be forceful and to speak my mind. So I want to just reflect on a couple of things that John said. I think that as we challenge the systems that we're all facing with, we have to first and foremost own the fact that our healthcare system has been rooted in white, cisgender, male, patriarchal hierarchy for decades, centuries, since for 401 years. And unless we change how the power is shared in healthcare, in pharmaceutical industry, in schools of public health, nothing's going to get better. And it's not our job to like bring care to people and just dump it on them, but it is our job to work with communities as equal partners. They know as much about communities know as much about their health as we do. And so one of the things that we have been proposing at the School of Public Health, where I'm also the dean, is a modern public health paradigm which marries the work of industry with community, with government, and with academic public health to actually affect a change. Because unless folks are all at the table together having a conversation, we're going to continue to have the problems, whether it be COVID-19 or HIV, which, by the way, in our country, HIV still affects 40,000 people a year, mostly Black men, who are gay. So the structural barriers, the structural inequities are perpetuated, not just in continents beyond our own, but certainly in our own country. And you just don't need to look very, very far to see, even in my hometown here in Newark, of what's going on with health issues. So I challenge my students every day to be activists. And I challenge you to be activists. It's not enough to be an academic. It's not enough to be a scientist. It's not enough to be an educator in this particular moment. It's time to be an activist. Because as we have seen over the course of the last 4 years, politics shape public health. And if we don't challenge the politics that continue to marginalize and oppress, we're not going to see an improvement in anybody's health in this country. Last point. Kristen and I, Dr. Krause and I, I'm sorry about that, Kristen. Dr. Krause and I are going to be talking about LGBTQ health issues and COVID. I just want to start also by saying, I also challenge us to stop thinking about people living in one box. Because gay people are Black people, and Black people are immigrants, and immigrants are people from New York City, and people from New York City are like everybody has intersectional identities. And so to assume that everybody fits squarely in one box, oh, here's the LGBTQ people, and this is their reality, is different from the Black people, and here's their reality, is like this very, very, it reminds me of those schools that continue to have cultural awareness months instead of undoing social studies so that every culture is praised and honored all throughout the year, as my wonderful husband is doing in New York City, teaching social studies to middle school kids. Okay, so I'm done with my tirade now. Now we can go to the slides. And so we're going to talk to you today about our research center, CHIPS, which has been, which was a center that I founded at NYU some 20 years ago. I was at NYU for 19 years, and I've been here at Rutgers for the last 3.5 years. My blood has changed from, violet to scarlet. And so I am fully embedded in my new institution. And the center that we have founded is a really critical element of the work we're going to talk about today. We're going to also talk about LGBTQ people in general and their health, talk about a study we've just enacted. You are the first to see the data from the study. And let me just say this, as an applied statistician, as somebody who has a PhD in applied statistics, I just want to say we're going to show you very simple data today. There are more sophisticated analysis to be done. So just know this is the first pass through that we wanted to share with you. Go on, Kristen. So our center, the goal of our center is to improve the lives of those people affected by multiple intersecting health problems, including HIV substance use, using both social science and public health research approaches. And next slide, we work with and for the population. So at the School of Public Health, we have adopted a slogan, keeping the public in public health, because I will tell you very honestly, when I first arrived at Rutgers about 3.5 years ago, public health was being done behind computers, and that's not the way I do public health. Public health needs to be done actively with advocacy and activism in the community. And so we work with and for the communities and populations that we study. And I use the word both communities and populations because I think populations consist of communities, and people can be in many communities and in many populations. And again, this intersecting notion of all of these things. And the work that we do is highly translational. So, while we do everything we can to get our work out into the scientific literature, we also write op-eds and go to meetings and go to events where we share in real time, like this event right here, what's going on with our studies. Next slide, please. The program that we've developed also, and Kristen is the deputy. Kristen started working with me at NYU, and then she eventually came with me to Rutgers and just finished with her PhD. So she's my first graduate from Rutgers. A big part of what we do is develop the next generation of scholars. And so I'm almost 58 years old, and so I don't know how much longer I'm going to be doing this, but I know what my responsibility is, and what my responsibility has been over the last 20 years, which is to make sure that I, as best as possible, create a new generation of scholars who are going to take the work to a whole other level and hopefully do it even better than I'm doing it right now. Next slide, please. So we currently have 3 studies that we're doing related to COVID-19. The first that we're going to talk about today, our LGBTQ COVID survey, which completed last July. A study called Chronicle, which is a study of individuals living with HIV with regard to their experiences of COVID and tapping into a resilience versus a deficit model, trying to understand how HIV positive people are living with through this era, which for some people, as Kristen will tell you, is for them as the second pandemic in their lives. And do they have the tools from their first pandemic to manage the second? It's all very interesting. And as all of you know very well, the literature about COVID-19 and HIV and antivirals is really complicated. And is it protective? Is it not protective? It's a very complicated situation for HIV. But I will say to you that what we are seeing is that HIV positive people who we might have thought were highly vulnerable to COVID-19 and to mortality are not manifesting in the way we had expected at the beginning of the epidemic. And finally, a study on seroprevalence of antibodies in Newark, in Essex County, where we are doing time-space sampling and doing testing at bodegas and supermarkets and big box stores to look at antibody presence, given all its limitations, and we know there's limitations with antibody testing in the population, to get a better sense of exposure. Next slide, please. So, I'm building on also what John said, and I think this taps into it very, very well. Too often the work we've done has been rooted in a biomedical perspective. The smart doctors come and help the people, right? And my perspective is rather a biopsychosocial perspective, which believes that any disease absolutely has a biological basis, but it also has a social structural basis and a behavioral psychological basis. And if we think about HIV in particular, we can think about COVID-19 too. If HIV was purely a viral pathogen, then it would equally affect every population in the United States, but it doesn't. And those who are most marginalized because of their race or their sexual orientation are the ones who are most affected. And the same pattern emerges for COVID-19. So in order to affect a change in a really, really important way in the health of people, you have to attack the virus, you have to attack the disease on all 3 fronts, much like we attack HIV with a triple combination treatment. Next slide, please. The other thing that I really believe in and hold dear to my heart is this notion that diseases don't exist separate from each other. So where you see COVID, you see HIV, and where you see HIV, you see addiction. Where you see addiction, you see mental health burden. Disease, we tend to treat people like as if they have only one disease, but in fact, people have what we have talked about in literature for 40 years as comorbidities. I call it syndemic. And a syndemic is an idea that the health conditions coexist and they exacerbate each other. And when you have one health condition, it makes the other health condition worse. Next slide, please. And finally, and importantly, this notion of intersectionality, which guides all the work that we do, recognizing that the people we study, yes, our research center is focused mostly on LGBTQ plus individuals. And in fact, Kristen will tell you that we were recently asked to write an article about the health of the population. I said, I need 6 chapters. I don't need 1 chapter. The chapter on L is different from the chapter from G and B and T and Q. And so I say that also trying to point out the fact that in this LGBTQ population, it's not a monolith. So folks across their sexual orientation and gender identity are not the same. And they also bring to the table their race, their culture, their ethnicity, their nation of birth, all of these issues that define who they are. And so focusing on the role of intersectionality in healthcare delivery is really key. Next slide, please. And so Kristen's now going to take us through just a brief summary about the health of LGBTQ population, and then we're going to dive right into the study findings for you.
And I'm going to highlight the word brief. So this is also stuff we can discuss further in the breakout rooms, but thank you again for having us. And I can't control my own slides, go figure. So one of the challenges that we have within this field of LGBT health, sexual and gender minority health, whatever you want to call it, is that to date, we don't have an accurate estimate, both here in the US and more important globally, of how many LGBTQ people there are. This is for many reasons. One of the biggest is that, especially here in the US, good questions around sexual orientation and gender identity are not included in these massive surveys such as the census and the American Community Health Survey. So what we're often then forced to do is kind of compile these other surveys like BRIFIS, the Behavioral health surveys, and we're kind of compiling all these numbers together, and what we believe is an estimate. So, according to Gallup, our most recent estimate is that there's close to 11 million LGBT individuals in the US. I'm sure Perry and I would argue that it's much more than that. Also contextualizing the fact that, any identity within this umbrella that we're talking about lies on a spectrum. And so folks don't necessarily fit into one box or another at one point in their life, and may transform their identities over time. And so with that, within this community as a whole, we see that there's many different health conditions that Perry has already mentioned that tend to are more exacerbated. So within lesbian, gay, and bisexual men and women, we see that there's overall, self-rated health is less compared to their heterosexual counterparts. We see higher levels of different chronic illnesses, a younger age of onset for disability. And this is a common theme weaved throughout all of these subgroups that we mentioned. And specifically for our trans folks and trans non-binary folks, there's a whole other set of issues. And again, it's important for us to contextualize that sexual orientation is not the same thing as gender identity, even though it often gets thrown into this umbrella. Sexual orientation is rooted in attractionality, and gender identity is rooted in an individual being and identifying with your sex assigned at birth. So for our trans folks, we see health challenges around use of hormones. We see increased prevalence of an incidence of cancer, often associated with biological gender, but often associated as well with any type of hormone replacement therapy, gender transition. The data is still very slim on that. And many of these other mental health and psychosocial challenges, substance use, depression, anxiety, higher levels of STIs. So many things that you would think would impact these communities definitely are. And so when we think about how this relates to COVID, there's been a slew of advocates, including Perry and myself, and many of our colleagues around the country and the world, really concerned about what the impact of COVID is having on our communities. And so we put together this survey back literally almost 2 weeks after the onset, where we started planning it. And I'm going to turn this back over to Perry in a minute, but we really wanted to do our best to get a representative US sample, looking very briefly at behavior around sexual behavior, substance use, employment, testing, all of that kind of stuff in relation to COVID. So I'm going to turn this back over to Perry so he can introduce the study a little bit more.
Yeah, and we did. So thanks, Kristen. And, we did a study after the Pulse shootings also in a very similar way, where we were able to really see that the Pulse shootings actually made LGBTQ people much more afraid for their safety and their well-being, something that we published that is accessible to all of you. So we come to this work, with this, very clear notion, again, of this endemic that COVID-19 cannot be thought about in the LGBTQ population separate from all of these other issues, that STIs and co-infections and malnutrition and mental health and violence and what have you, and that all of these health problems are fueled by these structural inequalities, including food insecurity and poverty and homophobia. And LGBTQ people are not rich. There's this notion that somehow LGBTQ people are rich, but LGBTQ people are often people who work in service industry, who have minimum wage paying jobs, who have been affected by COVID-19. And again, the diversity exists within the population, so that it is not the experience of a white gay man who is a dean of a school of public health, at a university, is very different from the experience of somebody who doesn't have all of those benefits and all of those privileges. And so again, really important to think about the structural inequities that exist not only in the population at large, but in the population of LGBTQ people, sexual and gender minority people more broadly. Next slide, please. And so we did we turned it around really quickly. We did 2 waves of data collection, and I'll tell you why we did 2 waves, because in the first wave, because we were incentivizing people, we identified bots who were taking our survey, which we've since cleaned up. So we cleaned up that data, and then we did another version in June, from June to July. To be in our study, individuals had to be over 18, identify as LGBTQ, and live in the US or a US territory, which we were able to verify. We did a really decent job in the stretched out United States here. It's really stretched out, isn't it? In the stretched out United States here to get everyone from almost every state, except which one, Kristen? Some red state.
Wyoming.
Yeah, except for one, Wyoming. But we did a very good job in getting people from almost everywhere, as you can see from here. We ended up with 1,090 participants, diverse in terms of their age, less diverse, unfortunately, in terms of their race, ethnicity, but there was we tried really hard, and diverse in terms of these other issues with, close to 40% from the Northeast, 12% from the Midwest, 20% from the South, 10% from the mountain area, 16% from the Pacific, and 3% from the non-contiguous United States. So a snapshot there of what we would count. So again, you are the first people to see this. So we asked them a set of questions, and what you see at the bottom is, have you had a PCR test? Have you had an antibody test? Were you PCR positive? And were you antibody positive? And you see pretty consistently that there's no differentiation across race, both for PCR and serology. There is a trend towards significance for the PCR positivity, with Latinx people, indicating a higher rate of infection at 19%. Similarly, in terms of antibody positivity, again, bearing in mind that antibody positivity, unlike most people, my antibodies continue to persist 9 months into it for some reason. Most people lose their antibodies. At the time of testing of these individuals, Black folks, and white folks, about equal proportions of antibodies present, showing exposure of the disease across all aspects of the population. And I want to say something also here that I think harkens back to HIV. At the beginning of the HIV epidemic, we saw a disease in the United States that was spread along the socioeconomic spectrum, but since that time, in 40 years, has lodged itself at the low end of the socioeconomic spectrum. I think that the COVID-19 is doing that at a much more accelerated rate, just like it's killing people at a much more accelerated rate. Next slide, please. In terms of sexual orientation, we also asked them about whether they tested and what their results were. And what we find here is that the gay and lesbian population have not only had a higher chances of testing for antibodies, but significantly more likely to have PCR positive results. And when you break it down and you disentangle the gay from the lesbian, it actually turns out that it is this number of 15% for PCR positive is being dominated primarily by gay men. Next slide, please. We also looked at differences in terms of gender identity, and here we see, once again, a tendency of gay men and trans women to more likely to have had an antibody test than others. Next slide, please. And in terms of HIV serostatus, not surprising, HIV positive people who are very, 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 very conscious of their health, because they have to be conscious of their health, slightly elevated rates of PCR testing, significantly more serology testing because they wanted to know if they've been exposed. And with this data that's coming out about CD4 interactions, whether it's CD4 diminishing or CD4 activating, I think HIV positive people have an area for particular concern with regard to COVID-19. Next slide, please. And in terms of nation of birth, what we see here, and here's how it plays out, again, in terms of immigrants in the United States, and in terms of likely what their jobs are, what we see here is that non-US individuals more likely to have both PCR testing and serology testing, probably because they're more likely to have frontline workers. This is an interpretation that we will have to bear out through the analyses. And in terms of geography here, again, this was at the time of our survey, the Northeast was the part of the world that we were most talking about, more likely to have a serology test. Next slide, please. And in terms of employment status here, also what we found is that people who were employed full-time, again, hypothesis here that these individuals are full-time workers, frontline staff, not just healthcare providers, right? But UPS workers and United States Postal Service workers and delivery people, the forgotten heroes, because we tend to we bang the pots and pans for the doctors, but we don't bang the pots and pans for the post people. And I think we need to bang them for all of those people. But they are testing, they're having PCR testing and serology testing at higher rates, likely because they are more likely to have been exposed. Next slide, please. And here is a breakdown of the cisgender gay men in our study. Almost 20% reported having a PCR positive test. 1 in 5 gay men in this study reported being PCR positive, which, as you will know, from the prevalence data in the United States is much, much higher. Close to 40% reported having antibodies. So gay men seem, of all of the populations, and trans women to some extent, within this sample, to have been the most affected and most impacted by COVID-19. And this again has to be borne out. And we need to figure out what the reasons are that it's actually manifesting this way in this segment of the sexual and gender minority population. A lot to like chew on here. So one of my other favorite things that we started to look at is we looked at sex and drugs after and before COVID-19, and we marked March 13th as the beginning, as demarcation point. We're not going to show you sex data, but I'm sad to report that there's less sex since March 13th. Sorry, but there's more drug use. And so what you see here in this chart on the left in the green and yellow is that 82% of individuals reported alcohol use in the past year, but if you combine more and the same, about 79% more or the same, with close to a third of the sample indicating was they were relying on alcohol much more before since COVID-19 than before. A phenomenon that also, next slide, plays out when we look at tobacco use, another drug that we tend to forget. Here, I'm looking at the state-sanctioned drugs here because we always talk about cocaine and meth and all of that other stuff, right? All that bad stuff. But in fact, when you look at HIV and other things, alcohol is one of the biggest facilitators of HIV transmission. It's not just meth, you know. What we see here is, close to 40%, again, more tobacco use. And the next one, close to 40% more marijuana use, since the onset of the pandemic. So I think what you are hearing in the literature is very true to what we're seeing here, which is that folks are turning to substance use in the absence of other, strategies in order to be able to cope. And it's certainly playing out in the LGBTQ population. It will be interesting to see what's happening with the other drugs. I think it is much harder probably to access other drugs that are not state sanctioned because of having to go out on the street to get them or have them delivered to your home, and how that is interfered by because of the pandemic. But we'll look at that analysis too. I just wanted to add one more thing before I turn it over to Kristen, which is, I think it's really critically important as we continue to I just did a whole thing with NJ Spotlight about Thanksgiving. Could you all just stay home, please? And not stop spreading the disease. That's my first request to you. And number two, the vaccines are gonna work effectively and get to people who need it if the administration that is currently in the White House continues to delay the transition to the new administration. So every day that a delay happens, more Americans die. Last but not least, it is my great hope under a new federal administration that we will actually have demographic data on what somebody's gender identity and sexual orientation is. I went to a meeting a few months ago and said, somebody said to me, sexual orientation, that's a social determinant. And I'm like, no, it's a demographic. So we need to shift our mindset to gather data on sexual orientation and gender identity like we do age and height and weight and race and everything else. And so I encourage all of you to fight for that, because we need to look at what the intersections are that actually affect the health of the population. I'll turn it over to Kristen.
Thank you. So he stole my next slide, so I'll skip over that
sorry.
one, but okay. But just some general implications, and again, we can talk about these more in the breakout rooms, but really understanding what the impact and the intersection of COVID-19 with every other health outcome and disparity that impacts these communities, and really making sure that healthcare providers and practitioners are tending to a holistic perspective of health and not just a mental health or physical health. And as Perry kind of just alluded to, there's very inconsistent collection of demographic information on COVID testing forms. And so if you're not even asking folks what their sexual orientation or gender identity might be, or sex assigned at birth, we have absolutely no way of telling from a 10,000 foot view epidemiologically what the impact is on these communities.
Kristen and I worked really hard over the course of the summer. We sweated it out to get healthcare in. If you go to New York City, which is my birthplace and that place that I go back to on the weekends, you go to the doctor, they assess your sexual orientation and your gender identity at the doctor's office. We're not doing that in New Jersey, except for a few places. So we need to push really, really hard to do this in New Jersey too, because I think what we're going to see in another study that we're doing right now is that a lot of folks in New Jersey who identify as sexual gender minority are going to Philly or New York to get their care because they don't think they can get their care here in New Jersey. And we need to normalize it. Okay, keep going, Kristen.
And well, this is countrywide too. So when I wrote a commentary this summer, only 7 states had implemented any type of widespread rule and regulation for this. So again, this also kind of comes back to the census and American Community Survey. You know, it's really unfortunate that now we have to say like maybe in 2030, because that's 10 years from now. So, but more to come on that. So we just wanted to make sure that folks had some of our favorite resources. The Fenway Institute, for those of you who aren't familiar, is one of the leading, high-level research policy organizations involving all things LGBTQ health, and some additional resources. But I'll let Perry talk about this little gem of ours real quick.
So yeah, very quickly. So and a shout out to BMS for their support of this also. But so 2 years ago, Kristen and I were sitting by. I don't know where we were sitting. We were bemoaning the fact that there was no public health journal focused on LGBTQ health. There were a lot of psychology journals and such like humanistic journals. So, what do you do when you have all the time in the world, which we don't, is you create a new journal. And so we have, and we launched it last year, and its first volume has been a huge success. And it is available for free. It is available for free for everyone for the first 2 years. And thanks to the efforts of Paul Shea and others, through the support of Bristol Myers Squibb, we are going to continue to be able to work on this journal. We have a COVID issue coming out in issue 4 in the next month. I also have this really cool editorial in this one about politics and public health that I encourage you to read. And then last but not least, when I first came to the school also, I gathered my faculty in there and I said, well, can we think about an LGBTQ health concentration? So, because, or a certificate, knowing that, the issues of LGBTQ people are complex and varied. And they came back to me and said, no, we don't need a certificate. You can't learn everything in 2 classes or the 4 hours most medical doctors get about LGBTQ people, but you actually need a whole concentration. So we have the world's first LGBTQ concentration in public health. So please spread the word about that. Thanks to everyone. And here's our, that's my old Bitmoji, girl. Anyway, so here's our Bitmojis. Here's how you can get to us.
Will very much look like
Thank you very much for the opportunity to be here with you. It's been awesome.
Oh my God, Perry, Kristen, I'm just going to echo the power of the comments. Your presentation is incredible. We are going to make a change to the agenda because there's more here than we can give justice to in the amount of time. So let's go right into our next panelist. And Patty, if we could just have you say hi, and then I'll let everybody know what the change is after we do a couple more intros.
Sure. Hi, everyone. And thank you so much, Dave and the GRIT team, and of course, our colleagues at BMS for inviting me and John to be part of this. I'll be hosting a breakout today along with Steve Kramer talking about health equity, which really has 3 definitions that we're going to be paying attention to. One is certainly outcomes, that optimal health is achieved for all people, but how do you get there? So also assuring the conditions that will allow for optimal health. And then finally, I think what has now become much more broadly understood and embraced is the social justice aspect, that everyone deserves a fair and just opportunity for optimal health. It's not fair that many people are suffering unnecessarily with completely preventable, certainly reducing the disease burden that could be much less if we really just committed to quality healthcare for all and great public health as well.
Stephen, can we have you say hi and introduce yourself?
Hello, my name is Stephen with a V for Victory. I'm a pharmacy student at St. Louis College of Pharmacy. I'm learning sign language to better communicate with the deaf and hard of hearing. 4 years, I'm really excited to be here and be a part of everyone coming together. 4 years ago, I had the opportunity to work with an 11-year-old. His biological family wasn't able to give him the support he needed as a deaf person. So for the first 11 years of his life, he had no language. He couldn't read, write, talk, sign, lip read. He didn't even know his name. Obviously, no language means no friends. And it was just really devastating to see a human being in that state just live like that. Thankfully, he was adopted by another family, and all 7 of them learned sign language to communicate with him, and it completely changed his life. And it was just so exciting. He learned his name, he was able to make friends. And just, I had the opportunity to watch his transformation over the course of the year. And it was just so exciting. And my desire is to make sure that happens to all of my patients as a future pharmacist. It's Stephen with the V for Victory, where the E before the V stands for educate. I want to educate healthcare providers on accessibility for people with disabilities. And then the second E stands for empower. I want to empower people with disabilities to be advocates for their health. And to do that, I invite people from the deaf community as well as people with disabilities to give presentations. And that I kind of wanted to show, I bought my posters out. I have these around the campus. So they come and educate the pharmacy students on how to better advocate for people with disabilities. And then I collaborate with SNAFA, Student National Pharmaceutical Association, in partner with Centers for Independent Living. And we go out into the community and then educate and empower the community with what we learned at the school. So yes, I'm really excited to be here. Yay, thank you. Oh, yeah, I mean, what you say is true. So this is the sign for applause. So yay.
Stephen, you are the embodiment of collaboration and co-creation. We didn't know each other a couple of months ago, and you are a new miracle in my life.
Yay. I was scrolling through Facebook trying to see how do I do virtual health fairs because of COVID. And then on Facebook, it popped up and it was like, come to the COVID Advocacy Exchange. And I was like, oh yeah, that sounds exciting. So, and I reached out to Dave. I attended one of his COVID advocacy events. And then we met and I told him my story and he was like, yes, let's collaborate. And so yes, as I said, I am very excited to be here.
That's wonderful. And Kemi, we're going to change the format, so please don't feel any need to rush at all. Just go right in and do your introduction.
Okay, I was wondering that as well. But hi, everybody. My name is Kemi Oshandina, and I have the wonderful privilege of working at BMS with many of my colleagues on the call today. And I work on our U.S. oncology patient advocacy team, working with representatives from organizations similar to many of you on the call today. So really honored to speak on this call today and talk about this important topic. I'll be co-leading a breakout. Well, I'm not sure if we're still having the breakouts, but the topic of our breakout was COVID-19, specifically the impact on racial and ethnic minorities and how those disparities among underserved communities have really exacerbated COVID-19. And I think as Dr. Perry said, it's really the second pandemic on top of everything that is going on in 2020 this year with COVID and the racial unrest. So that was the topic of our discussion. And myself personally, I actually started my career out with the BMS Foundation with John and Patty, and specifically in South Africa. So global health and health equity. I'm an immigrant from Nigeria myself. So global health and health equity has always been a passion of mine. And really having a firsthand experience with my father and my grandmother in Nigeria, who didn't have access to the medication that she needed at the time. So really passionate about the theme of our discussion today and taking action to address health equity. So thank you.
Thank you so much, Kemi. And then Dr. Fields, there's so many screens. Are you with us, Dr. Fields?
Yes, I am. Can you hear me?
Of course, perfectly.
Hi, I'm Anthony Fields, and it may be obvious from my name that I'm my father's namesake. And not only am I his namesake, but I'm his legacy and his dream. And every day I am grateful for what he's instilled in me, the grit. Thank you, Dave, for that amazing name, humility, compassion. Also, I'm passionate about collaboration. So I work in global strategic collaborations at Bristol Myers Squibb. And being in strategic collaboration, I firmly understand that it's the wellspring that will bring about innovation, that will address all of the world's complex problems. Also, I'm enveloped in the sphere of STEM since 3rd grade, and I'm having my PhD in microbiology and immunology. My goal at this point, similar to our guests, have been to inspire, mentor, and the next generation so that they can re-script the narrative and reclaim their possibilities and the hopes. In hopes that they can find a cure for diseases such as pancreatic cancer that prematurely shortened my dad's life. So I'm thrilled to be here with this group, which you play an incredible, important role in how we pull together and innovate to bring great solutions that will change the complex problems such as health equities. So thank you so much, Dave, for this opportunity.
Oh my gosh, yeah. Because of how powerful this is and also how short our time is together, I don't think we can rip each other apart. I think this is a really important moment to be together. Also, our technical vendor dropped the ball and they won't let us do breakouts right now. So we're gonna stay together. So is everybody okay if we stay together? Okay. Okay, so let's stay together, and I believe there are no coincidences. So at the end of this conversation, I love it, thank you. At the end of this conversation, we were gonna ask everyone if you would like to be involved in each of these areas going forward. And our intention is to create working groups to make real change in each of these areas. So with our 3 groups, LGBTQ+, accessibility issues and optimal outcomes, and racial and ethnic disparities. If any of you want to, in the chat function right now, write a 1, a 2, or a 3, if you want to spend more time having conversations and really creating outcomes together. So write a number 1 for LGBTQ+, if you want to be involved in changing the future for the better. A number 2, if you're interested in accessibility and optimal outcomes for all people. And then a number 3, if your passion is racial and ethnic disparities and changing those. All right, so our team is gonna grab all these. Oh my gosh. Oh my gosh. All right, so.
Everyone.
What's that, Kemi?
I was just saying thank you. I'm seeing all of the numbers coming too.
Yeah.
So we're going to send a survey out. This is how we were going to capture this initially, because our plan for 2021 is to move beyond conversation to action and start to create the change that we want to see in each of these areas. So everybody that's put this number will reach out to you and share more about that. And then the survey that goes out, please share that with anybody else that wants to be a part of it. And so we will move from this conversation today into creating working groups with outcomes and providing resources and expertise in 2021 to work on that together. So thank you for everybody who jumped in on that, and also for being flexible on the change of the approach. I can feel that there are people that need to contribute to this conversation. So who would like to jump in and just go with where we are right now? Anybody, please.
Hey Dave, this is Perry. I don't want to jump in, but I just need to tell you all that I have to go because the paparazzi is calling. And when the paparazzi calls, I tend to respond. No, seriously, I'm sure it's another interview about not having Thanksgiving, which I'm totally fine with. But I loved being part of this, and I'm honored to have been part of this conversation. And I leave you in really amazing hands with Kristen.
And we're not letting you get away, Perry, so we'll be back.
Thank you.
Thanks, Perry.
Please, anyone, go ahead, sorry.
About contextual factors that influence patients' outcomes, and particularly for the LGBT community. And we know that the social conditions in which people are born, people grow up, work, experience life, these are all significant and influence their health outcome. However, what we have seen is that there's a clear differential when it comes to access to care along the race and ethnic lines. And even when we look at downstream analysis of patient outcomes, it reveals that disparities accumulate across that entire healthcare continuum. And this is only compounded when we're looking at using like an intersectionality framework and looking at additional dimensions such as economic status. And even when analyzing health outcomes along the diversity dimensions, like let's say sexual orientation, worse outcomes are observed along race and ethnicity line. So now when we are considering how organizations across disciplines and sectors attempt to formulate solutions, those traditional models of addressing these disparities by engaging just underrepresented minority communities, those fall short. They fall short because those health equity, those health outcomes are not changed in a meaningful way. And by working separately, and then this is what's wonderful about this opportunity to bring together this very diverse group of people, by working separately and focusing downstream of the patient journey, a lot of resources expended to catch and reduce health disparity, and we don't get the outcome. What we know is that that if we can focus the interventions upstream on structural and social determinants of health, those will have more, and also by advancing those interventions collaboratively, either in multi-sector, multidisciplinary manner, that will, and also what we're doing is bringing together our complementary tools and resources, then that's going to deliver the greatest benefit.
If any of our other panelists want to share what you were going to, jump right in, or anybody, it's an open floor.
I think this is Patty. I'm definitely interested in hearing from the participants how you feel the opportunities to advance health equity, to address some of these disparities, to take the holistic approach. How is it starting to show up in your work, or has it already been there? What do you see as some of the most important things to do going forward? It's been really, I think, affirming to see that because of the understanding that's really been created about health inequities, how severe they are, how they really do exist, and they end up with loss of life and much greater suffering by certain populations, as we've seen with COVID. That new awareness, that new consciousness, I think, in folks who have maybe been on the bench on these issues, or who have not understood them before, they get it now. They know that it's important. So just be interested to hear from the folks who have joined us just in the patient advocacy space and the patient supportive service space. What are some disparities you'd like to work on, and ones that you've seen that you'd like to set aside, and any work that many of you probably are doing great things. So any work you're already doing in this space would be wonderful to hear. Thanks, Dave.
Patricia, I'll just make a, sorry, go ahead. No, Tina Marie, please.
Oh, sure. Hi, Patty. For everybody on the call, my name is Tina Marie Duff. I am the DAWN, which is Differently Abled Workplace Network ERG lead at Bristol Myers Squibb. I'm a Caucasian female, middle age, and I'm looking very disheveled today with my hair pulled back in a ponytail to do a visual descriptor. Thank you to the ASL interpreter as well. So Patty, one of the things that representing the disability community, and I had the opportunity to speak at a GRIT forum, so thank you, Dave and team, that I am seeing is kind of like the next step for the disability community beyond ADA, which is this call for economic and employment equity. And I think that looking at the connection and the intersectionality with the disability community, as well as communities of color, there's a lot, LGBT community, there's just a lot of intersectionality. And once we see a closing of some of the gaps of employment, we know that only 30% of people with disabilities actually have employment, and that's common around the G10 countries. We'll start to close some of that gap on the health inequities that we're also seeing. So I applaud the financial community that is having a call to action for more disability employment, and the corporations that are putting in initiatives like Bristol Myers Squibb of having an intense focus on the disability inclusion and hiring practices, and also more and more organizations like Disability and AAPD that are also raising the bar and kind of creating a benchmark for organizations to look at where they're at today and move it forward, because I think this is one way we can start to address that gap.
That's great.
Thanks, Tina Marie. I just wanted to bring up what I think is a really important point, something that Perry said, that, you know, there are, as he put it, there are Black people, there are gay people, there are gay Black people. This is a whole issue for everyone. And separating these groups and recognizing that, you know, that was just part of the breakout, and that we would come together at the end and look at crossover between the groups, as well as kind of key points that we need to address for specific groups. I think that's a key point. One of the things that I wanted to recognize is that within our hospital system, it's become much more driven by profit, and because of that, it's very hard to get access for all people. One of the things that I've recognized a lot of, especially in the community I live in, inner city hospitals have closed down because they're not as profitable. Hospitals have moved out to the community. Into the suburbs, and that's a huge issue. I imagine stuff like that is happening across the country, where hospitals that serve minorities and serve the underrepresented aren't able to stay in business without support from these larger academic institutions. Things like that, kind of these basic points where we need to increase access, we need to improve quality of healthcare for everyone. But access is a huge point, that we need to strengthen our national efforts, our coordination, but also our state efforts and our local efforts. And within our individual communities, there's really these cross points, and there's also specifics that we need to learn. So, you know, what are the things that we need to understand about the LGBTQ community that really speak to their needs and their individual needs as well? Or about the Black community, for instance, understanding clinical trials and the lack of confidence that a lot of Black people have in our healthcare system because of a long, huge history of systemic racism and problems and clinical trials run without their knowledge. So there's all these key points, and we want to bring those all together, as Dave said, and have key working groups in the specific areas, but also have a working group that addresses all these this crosstalk, these areas where we overlap. So I just wanted to say that, and thank you everyone for being here, and appreciate you guys dealing with the technical issues.
So I did want to, this is Anthony, so I did want to talk about clinical trials, because I'm not sure who is in the audience, but I don't think it's an overstatement to say that the lack of diversity in clinical trials is as much of a moral issue as it is a scientific one. And just to level set for those who may not understand how, you know, these quote unquote human experiments fit into the treatment landscape, like they don't just benefit the company or the institution executing them, but they serve as a critical part of the patient journey that expands options when the standard of care and the normal sequence of medication interventions have been exhausted. So it literally gives people more time, and that's additional time to get another hug, to impart a lasting wisdom, to make more memories. And that should be accessible to all. And dealing with some of the trust issues is something that we're continuing to work on as well. However, at Bristol Myers Squibb, we've been able to do, we've executed a forum where we had best practices, thought leaders come in to share best practices. And if you're directly approaching the patients and the message is coming from a trusted voice, they will participate. The Black community will participate in clinical trials. So that is definitely a focus of ours as well.
I'm not sure if this is the correct place to be asking this, or if there are any other students. I'm not a pharmacist just yet. I'm a P3 at Southern Illinois University School of Pharmacy. My name is Shin Allison. I'm also the mental health chair for SNAPA, the Student National Pharmaceutical Association. So we do, our organization does focus on the underserved and those, a lot of the populations who are living like below the poverty line and don't have, access to all of the resources that are available to a lot of the population. Recently we do a lot of volunteer like flu clinics that go to areas that just don't have the availability or the access to those kinds of things. And like I was saying, I don't know if there are any other educators out there or preceptors or anybody who has that kind of experience, but I've noticed that our membership's kind of dwindling a little bit. I know it's a lot of it is COVID, but also at the same time, I wonder if you guys have any like ways of letting your message get out to other students out there or potential people in this field to really get them impassioned into what we're trying to do for the community, because me being a member and me going out there and actually making a difference in these communities, I can see what I do, and we can take the pictures, we can do like our testimonials and things like that. But I was just wondering, like, what other things do you guys, do to really get other people involved in this movement? And yeah, I mean, I don't know. It's just something that, I was thinking about, while we're talking about this and just trying to like get more momentum within the students. I don't know if this is the right place for that, but it does affect like our future, practitioners and our future, patients that we're able to help,
Allison, that's great. I mean, just something that I will offer. First, it's so exciting to hear about the amazing work that you're doing. And as a student, I know this is going to carry throughout your whole career. But I think a lot of organizations right now are just getting clear on this. So maybe working with SNAP, I think is the name of the group here, just to state that this is a priority for you. And then maybe think about, what are you all good at? What are the things that you regularly do really, really well? And then with your group, kind of put a health equity lens on it. Say, who do we reach now? Where's the next group that we have to reach? Or what are the issues we work on now? What are some other ones that we need to get involved in? Maybe we need to get more involved in not just medical solutions, but social justice solutions and become like an anti-racist organization, as an example. So I think that's, always starting at home. Like, you have great strength, you have a great group of people, and just think about, for my platform, how can it be mobilized against these issues, and sort of revisit that and see the things you can do. And then the other thing is that, fortunately, there's a lot of movement, and this is a great group to be involved in. There's a lot of folks on the phone and who are part of this community who are also taking actions. So you can also survey to say, is there somebody who we can also, hitch our wagon to, or put our efforts alongside, so that, as much leverage, as much good use of resources that we can get is really, really great. So I think I would just start that way is just know that you have strengths that can be used against this, and just do a little bit of thinking about, all right, what are the 3 things we're going to try and do in this next year? But most importantly, we're going to let the world know we are very concerned about this. This is a priority for us, and we'll be applying, our activities and goals against this. And then creating some areas for action, I think, might be a way to start.
Yeah, I think Patty brought up a really, really good point as far as collaboration in this space. And I think Anthony's was talking about it earlier as well, that it's really, there's so many different stakeholders when it comes to health equity, and we can't all work in silos, or we're not going to achieve our goals here. So really being vocal and intentional about your goals and your commitment to health equity and underserved populations, even if you're not addressing everything, but identifying what you do want to focus on, and then finding partners and collaborators or allies in that space. And I think the groups on this call are a great example. So I don't know if folks are shy today or they don't want to speak up. I wanted to hear a little bit more examples of what is everybody doing, or have you been able to achieve, or maybe you tried something and there were challenges. I think there's great things that we can learn from the challenges and lessons learned, and how to improve going forward as well. So feel free to chime in.
I'll speak. I'm on the GRIT team doing social media, but I have a son who's 13, and he listens to Jacksepticeye, who's a YouTuber who happened to have been who was very active. He closed down his gaming for a day for Black Lives Matter. And he had a message that said there's too much important in the world for us to be thinking about games. And then all of this money he donated. Then my son started to become more interested. And I'm thinking that This Is Us, the television program, and The Young and the Restless both have been doing health issues in their programming. So, you know, while we're cross-pollinating, I think we need to find out who are accessible gamers and YouTubers and writers, because I think people are not listening to people in authority anymore. And people are also not listening to advocates as much because of their, that's a soul separate. What am I trying to say? I think there's a way in which people can hear information through stories that is not yet fully tapped out. And I'm hopeful that we can find additional ways, in addition to everything here, to help support the Gestalt, having more information in subtle ways. Then I'll be quiet. Thank you.
That's a really good point. You know, really impactful stories that are culturally competent and going to the right audiences, wherever that may be. I think TV shows, like you said, and then YouTubers, social media influencers, like there's so many avenues, definitely.
Yeah, it's one of those things at the Bristol Myers Squibb Foundation. We spend a lot of time on monitoring and evaluation and metrics and data, because, you know, at the end of the day, we're trying to advocate for change in policy and treatment outcomes, and you can't move the needle on that without, without the data. However, in every one of those data outcomes, we're always asking our partners about the stories of how it impacts an individual, because that's what gets people mobilized. You know, payers may get mobilized by data, people will get mobilized by stories of human interest and how what you're doing is impacting an individual.
Absolutely. And also the non-traditional partnerships that foster, it's the non-traditional partners that are fostering innovation and have the ability and the potential to disrupt current models and bring about new outcomes. So, I think everyone, going back to the cell phone and how you had all of these new different sectors that could combine together. And then most recently, I was just looking at social media, and there was a collaboration between Beyonce and Peloton, and how they're going to use the digital access, they're going to provide digital access to HBCU students. And then so that's going to impact the health of a new generation in supporting their continued, healthy lifestyle. So again, it's to try to find that connection, and if you can pull a few people together, you'll be able to identify what that commonality is, and that non-traditional partnership is going to really make some, good disruptive change. So I think that that's wonderful.
Hi, my name is Monique. I am a global lupus advocate and also an ambassador, and I really do focus a lot on how do we improve the health disparities and the gap in the access of care for those with autoimmune diseases. And it's really been an interesting time for a lot of us during the past few months, and the access to certain medications, as we know, Plaquenil, hydrochloroquine, and we've seen how that's impacted underserved communities as well. And one of the things I'm just wondering if any of the panelists from the breakout groups, if you might be able to share. I've been really trying to delve in to figure out how I, as an advocate, as an ambassador, can be more sensitive to increasing health literacy. And we understand that that's an additional social determinant that impacts how we understand health information, how we digest it, how we share it. And it's different for all groups. Just as Perry was talking about communities and populations, that's different. And I'm just wondering if any of you have any takeaways that might help us to increase that health literacy within those groups so we know how to better inform them.
So as a result of the COVID, it was evident that, you know, misinformation and disinformation was rampant and negatively impacting communities of color, Black and Latinx communities. And so we leveraged a partnership with a particular community group. And what they're doing is developing a communication campaign for us to address some of the misinformation and disinformation. And so what we're pulling together is a community partner with trusted voices in the form of thought leaders, experts who, again, look like the community that we're talking to and also have the expertise behind them to, and then using that social media platform to disseminate the information. Prior to that, you know, we partnered with a company that, an organization that delivered a 20-second, it was a 20-second or more, which was a simple guide on hand washing and the importance of hand washing, 20 seconds of hand washing. And so Dougie Fresh, and then just tapping into that one resource, Dougie Fresh, they were able to pull the community organization that pulled this together. They were able to pull and tap so many different artists. And the way that that information disseminated was primarily through the individual artists disseminating that information on their Instagram. So sometimes it's identifying that one person. And one of our speakers, someone just mentioned that the traditional ways of communicating, particularly to the younger generation, is changing. So social media, getting in touch with either one person and having them disseminate the information for you and cascading that, that's what we found very, very effective. Hope that helps.
Hi, this is Devin. I work as a communication access professional and I help disrupt barriers at the hospitals and doctors' offices. And I do that by providing sign language, making sure they provide sign language interpreters. One other thing you can do to improve communication is to always have information there on your website, like videos with interpretation provided automatically and captioning and sign language interpreters already there in the deaf person's natural language as a way to access the information easier. There's also ways that you can add QR codes. And you can have a different catalog of different signs listed on your website as well. You can have different, access services listed for pharmacists and pharmacies. You can have other things that are common questions. You can have those recorded as a video so that you could show that to people for, making sure that there's more access for deaf folks. And so again, this is Devin speaking, not Mabel. That was Devin.
Hi, this is Elizabeth Iglesias with Lupus and Allied Diseases Association. I just wanted to contribute to the conversation and let everyone know this is just so very important. John, I really was focused on your talk because at Lupus and Allied Diseases, we just did a health equity and diversity inclusion, and we developed a work group, and we've revamped to take a look at ourselves and make sure that our organization looks like the people that we're working with, and we've revamped our statements, and we're taking a look at ourselves and really making sure that we are like our disease, really servicing the communities that are disproportionately affected by lupus, and looking like the people we are serving, being transparent. And so that was very, very wonderful. Karen, thank you, Kristen, I mean, thank you so very much for your presentation along with Patrick, because that was just amazing. When, with regards to the socioeconomic disparities that people are facing with regards to not being able to access Wi-Fi, or being able to have language barriers, when we have these um, new technologies and being able to access telemedicine, this is becoming an access issue for people. And when Dan said about access, this is my thing. What can we do to provide access to these people that are having these socioeconomic problems? Because I'm finding that this is a real deal problem for Latin people, for our Black communities, that you have barriers that are existing, that are socioeconomic problems that are causing access issues to care, because we are improving in technology, but our people are just not up to they're coming up to where they should be.
Is there one more person who'd like to jump in before we wrap?
I'll just, Elizabeth brought up a really good point. This is Tina Marie speaking. And access is a huge issue in many forms, whether it's digital access or physical access. And one of the things I'm seeing, and even in our own company, is a greater reach into the communities that are most impacted by access, whether it's building more clinical trials in smaller cities, or cities that may be impacted economically. I see that kind of shift. The other thing I just want to point out as a call to action, and Perry alluded to it, and many others have too, it's the concept of not for us without us. And that's the cry of many communities, including the disability community, that used to be related to policy. But as we're trying to sit around a table and solve for this, without having people that represent what you're trying to solve for. And there's many times I've been pulled into conversations to try to help an employee who is deaf, and the see-through face masks are not working for this employee, or review a website that is geared to a certain disease state, right? My first question is, who have you brought in that is being impacted with this to help remove the barrier, to address the solution? Because many times people know what they need. The other thing, and I can't remember who was saying that before, it might have been Devin, and thank you, Devin, for all your good points, is we are always looking at and auditing from a disability perspective how the community is engaging with us. And one of the things that we have quickly remediated is our external facing websites, right? Are they YCAG, which is website content accessible guidelines, so that individuals who are using screen readers and are part of the disability community, can they find jobs, right? The first thing is, can they find a job at BMS? Can they access information about our drugs, and so forth? So not only is there all these other very tactical things, but sometimes you have to go all the way back into the very beginning and find out, how are you engaging with the community you want to engage, and start to remove those barriers. And think about it as, we're removing barriers, we're not trying to fix a problem. Often we take a medical community approach to a disability of, oh, we want to fix it, where it's really, we just need to remove the barrier. So I just want to thank the team, and lots of great points here. I'm loving being part of these conversations. Thank you.
Thank you, Tina Marie. I don't know what I could summarize to convey how powerful this is. The only thing that comes to mind is that in one of our prep conversations this week, Kemi and Anthony's, I think I started yesterday crying because I asked one of our speakers how they wanted the audience to feel after our conversations. And the person said that if you're a person of color, that you feel acknowledged and heard and cared for, and that if you're in any minority group, you feel part of the conversation. And if you're not, if you're someone who isn't part of those groups, that you feel like you have brothers and sisters who want to create the change that we all want together. And I'm so glad we didn't break out into different groups today. I think it needed to happen this way. So just two things I'll leave us with to please continue this really important conversation. The first is tomorrow and Saturday is our global virtual cancer conference. It's an event that we created with Bristol Myers Squibb as our founding partner. Our opening presentation tomorrow is by an artist named Benjamin Scheuer, and he is a cancer survivor and will sing about finding your voice. And one of his new songs is called I Am Samantha, and it is the story of a trans woman and what her experience is like. He is such a powerful artist. I encourage you to join tomorrow and Saturday. We have several sessions on health equity and would love everybody here to be a part of that. You can find it, just Google Global Virtual Cancer Conference. And the last thing to leave everybody with is, Lodi, are you on? Is the survey going to go out on the 17th?
It is, Dave. It'll go out next week on Tuesday. Thank you.
Thank you so much. Yeah. So in the survey, we want to know what issues are most important to you, because that's how we're going to create the groups next year to really focus on change. So everybody that put your number in the side, will keep those and follow up with that and really start to create some working groups to make change in these areas. I'm speechless and don't know what else to say other than thank you. We'll see everybody again very soon.